Good morning, everyone. I hope everyone's doing good. Thank you for joining us for another eShadowing session. Today we have Dr. Theresa Scott, and she's going to be presenting about pediatrics and her journey to medicine and her specialty. And you can start, Doctor.
All right. Hi, everybody. Thank you for participating and tuning in today. I'm really excited to talk with all of you, and I hope that we can make this interactive and informal and just kind of really give you a sense of what I do. I love doing these talks because when I was a pre-med, I realize now how little I actually knew about the scope of medicine and what it meant to practice pediatrics or any other field for that matter. And so the field that I'm practicing in now, which is hospital medicine, I didn't even know was really a thing when I was a pre-med. And so I hope to give you a sense of what I do. So please, at any point, feel free to ask questions. I'll try to monitor the chat. But anything you want to chat about as we go through, I'm happy to discuss and take a break from my PowerPoint. So like I said, I am a pediatric hospital medicine doctor. I am actually still in fellowship for hospital medicine. So it's a 2-year fellowship and I'm just finishing up the end of my first year. But I'm going to tell you a little bit about my career path and what I actually do. So this is about me. This is what I've done. I started out an undergrad. I went to NYU. I went to med school right after undergrad, and I went to, it was NICOM back then, or New York Institute of Technology College of Osteopathic Medicine out in New York on Long Island. And during that time, I actually did a master's program as well. And it ended up being a scholarship program, which was a very big reason why I chose that school. And then from med school, I went into pediatric residency up in Westchester Medical Center, just north of New York City. And I stayed on there for an extra year to do a chief residency year, which is a big administrative year, just to kind of get a break from clinical work. And then now I am a PHM, or Pediatric Hospital Medicine Fellow, in New York City at Cornell and Columbia. So I've been very hyper local to the New York area, but I chose that for a reason because I knew I wanted my family to be close by during all of this intense medical training. And I want to get a sense of who you guys are before we talk, because I think it'll help me tailor a little bit of what I share. So just in the chat, if you want to maybe quickly type out if you're a freshman, sophomore, junior, senior, post-bac, whatever you are in your training in the pre-med world. Again, just kind of gives me a sense of where we are and who's in our audience. Okay, we got a bunch of post-bacs, junior, senior, okay. Okay, great. This is super helpful so that I don't have to talk about kind of college choices. We can focus on a little bit more about what to do towards the end of your college career, or if you're coming back to medicine from another career or after you graduated undergrad. That's very helpful. Again, similarly, if you don't mind, just give me a sense of, do you know you definitely want to do peds? You're not really sure, you want to do something else, but you're doing this just to get additional shadowing hours. I would love to get a sense of where you're thinking in terms of peds. And this is saying I had no idea when I graduated college, let alone barely when I graduated medical school. So if you're anywhere from that spectrum, it's fine. Okay, we have some people interested in peds. Okay, great. And some people not sure. Perfect. So I will, I'm very excited then to share some cool peds cases. And I think just kind of to show you that peds can be very different from what at least I thought a general pediatrician role would be. And so let's get right into it. So what is pediatric hospital medicine, or PHM? This is the bulk of what I see. So I see kids with pretty severe asthma, infections requiring IV antibiotics, really bad respiratory illnesses where they need oxygen or respiratory pressure and pressure support. Dehydration is very common. Kids who have, a a stomach bug and they can't keep up their fluids. Eating disorders actually has been really high in terms of my hospital load lately because of all of the kind of mental illnesses around the pandemic. And I also will see a lot of kids with seizures. So for the most part, this is what I see on a daily basis. And again, I'm only seeing patients in the hospital. So again, I don't know if I fully had an understanding of this when I was a pre-med, but I always thought pediatricians really were mostly outpatient, meaning they only were in a clinic, in an office setting. Very rarely were they actually in the hospital, but I actually only see kids in the hospital. I don't do well visits. I don't do things like vaccines on a regular basis. I see kids who are acutely ill in the hospital and from the start until the finish. Okay. So inpatient means hospital. And so why do I like PHM? I love the diseases that I see in the hospital. I love the cases that I just mentioned. I like the workflow. I like that it's a little faster. You don't have to wait a week for a lab result to come back. It's in a couple hours it comes back. And I like the schedule. It's intense when you're on, but for the most part, when you're off service or when you're not responsible for seeing patients, it's a nice break. You're not getting like a steady flow of patients. You kind of have a rush of patients and then you're off for a week, and you have a rush of patients and you're off for a week, something like that. Something to consider just in general is whether you want to be more of a community physician or an academic physician. Community doctors generally work independently or in smaller big groups. Academic physicians usually work with medical students, residents, trainees in large hospitals like Cornell or Columbia or other places where they have multiple specialties and kind of very research based. It's a different world. And it's just something that I've gravitated towards really since medical school. And then the other thing I like about it is that you have non-clinical time, like I said. So there's a lot of flexibility during my research time. There's opportunities for leadership in the hospital, being directors of the unit, being mentors for medical students and residents, and you can also teach. So I teach third and fourth year medical students as well as interns and residents in pediatrics. So what does a day look like for a pediatric hospitalist? It varies. I will start with that. But for the most part, I found that most places you'll do a day shift from like 7 to 5 or so. And then sometimes you're on call by the phone overnight. And so if a kid comes in, they'll talk to you over the phone, and the residents in the hospital will put in the orders and things like that and call me if they have any questions. And so I'll arrive at the hospital around 7:30. I'll read up on the patients who were previously admitted and learn about the new kids who came in overnight. And then usually from 9 to 11, sometimes 12, we physically go around and we see all the patients together. We talk to the families, we examine them, we come up with a plan. And I say we, meaning me, sometimes an attending, and the residents, nurse practitioners or PAs, whoever is the junior level member of the team. They will put in the orders and things like that. And so we go around as a group. And then after that, from really 11, 12 o'clock until the end of the day, we will sometimes revisit more complicated patients. I will go to administrative meetings. I write notes, kind of just tasks for the day. And then of course, if there's any new or really sick patients or patient events that happen, I will go see those kids as well. And like I said, when you're in an academic center, meaning a bigger teaching hospital like I am, you do research. And research is usually whatever you want, but you kind of have to do it. And so you get a nice flexibility of clinical time and research time. And during that research time, you can really structure your day in whatever way you want, as long as you get the work done. And so for the most part, my day for research is generally 9 to 5, 9 to 4, depending on what I'm doing. Sometimes it's much longer if I schedule all my meetings in a day, but I'll get to my office around 9, and then I usually do data collection or run some stats, kind of decide on next steps for a project. I often have either lectures for myself as a fellow, or I give lectures to medical students or residents during the lunch hour. You'll see that's very common in academic hospitals. And then the afternoons are often filled with more meetings. I'll do more data collection. I write a lot. I have to write research applications. I have to write grants, things like that. So a lot of unstructured time that takes some skills and some time to figure out how to structure once you actually get to this point in your career. But for the most part, I love it. It's like 9 to 4, so not too crazy. All right, and so now I want to talk about two cases. I want to make sure we get through them, so I only chose two for today, but two very common, or at least very interesting cases to me that we see in the pediatric hospital world. And so I would love for this to be a little interactive, but I also have zero expectation that you have any sense of either of these cases, because they're certainly not common or very well known to the public. I learned about them when I started my pediatric training. All right, so we have a 3-year-old girl who presented with a 4-day history of fever, rash, and puffy hands and feet, as described by her parents. She was seen by the pediatrician on day 2 of her symptoms. Now it's day 4. And she was diagnosed with a viral illness at that time and was taking Tylenol and Motrin as needed for her fever. But the fever didn't go away now that it's day 4, so her parents brought her to the emergency room. Our review of systems, so a quick scan of all of her body organ systems, reveals that she was fussy when she had the fever, and that she has a rash all over her body. So now we have someone who has fever, rash, and puffy hands, but she doesn't have any vomiting, any diarrhea, any cough, change in appetite, change in gait, or change in her wet diapers. And I put the wet diapers there because in pediatrics, that's actually how we often assess patient dehydration in little kids. If they stop having wet diapers or they have fewer wet diapers than normal, that could be the first sign that they're dehydrated and not getting enough fluids. All right. So as we progress through the case, the ED doctors, the ED team, look at the patient, examine the patient, get some blood work on her. And in their note, and when they call me to tell me about this patient, they tell me that she has a fever in the ED. And they also notice that she has really red eyes. But they don't have any, she doesn't have any cough, any congestion. Her lungs are normal. Her labs show there's a little bit of a white blood cell count elevation, so potentially a sign of infection or inflammation. She also has an elevated platelet count. And even though we normally think of platelets as clotting, platelets are also increased during infection or inflammation as well. She actually has a negative viral panel, so chances are, and this may not all just be from a virus. They get a urine sample, which is normal, and they got blood and urine cultures. So they literally take the blood and take some urine and send it to the lab to grow to see if there's any bacteria in it. And those are pending, and they won't be back for a little while. So in summary, we have a 3-year-old girl who has fever, rash, swelling of her hands, and red eyes for 4 days. And she has some signs of inflammation in her blood. Does this ring a bell to anyone? Anyone have thoughts on what might be going on with this little girl? And if you don't, you can just put in the chat that you have no idea, and we'll keep going through. Great, we have some awesome things coming in. So Kawasaki, question mark, roseola, question mark. Okay, good, we're all thinking. So roseola is from a virus. So that's certainly something that this could be. And I think that's a great point that you bring up roseola, because the viral panel we say is negative, but it only screens for actually about 20 viruses, and it can go up to, I mean, there's like hundreds of viruses out there that we don't even check for. So just because a viral panel is negative doesn't mean that there is no infection from a virus. And someone else said Kawasaki, fantastic. So if you don't know what Kawasaki is, that's totally fine. We're going to talk about it. But yes, that should certainly be on our differential because of some of these things that we're seeing. And we'll go over which symptoms I'm talking about specifically. In terms of a couple other differentials, so you guys are literally hitting the target right here. So Kawasaki disease is at the top of my differential right now, as well as there's still very strong possibility this is all just a viral rash, and you know, viruses can be nasty, and she just has a lot of symptoms from a virus. And then there's also something that anytime you hear of swelling, you should think of, especially facial or extremity swelling. It's called nephrotic syndrome, and it is when the kidneys get damaged in a way that they dump protein. So protein usually retains fluid, and when you dump all your protein, you get swelling, usually in your hands or your feet or your face. And so anytime I hear of a kid with a lot of swelling or edema of their extremities, this is on my differential until I prove it myself otherwise. All right, so let's keep going with her. You guys are doing great. So the ED doc calls me and says, hey, I have this kid. She got 4 days of fever. She has 4 days of swelling. She now has this rash. She has red eyes. I think she needs to be admitted because I'm concerned for Kawasaki. And so I say, okay, that all sounds fair. And we admit her to our service for observation. And the reason why we keep her for observation is because Kawasaki really is a clinical diagnosis. And that's why I think it's such a fun condition to work with and to treat, because it's based on clinical exam findings and blood work. And so you have to have these symptoms for 5 days. And we'll talk about the symptoms specifically, but we're gonna watch her overnight for her continued fever for another day, and then decide if we need to treat her for Kawasaki. And so overnight, she's fine, she's drinking, she's eating okay, but the next day she still does have a fever. And so now she has 5 days of fever with all these other clinical findings, and she develops a red strawberry-like tongue. You can kind of see what that might look like in this picture. So now we have a kid with a lot of things going on and 5 days of fever. And we're going to talk about Kawasaki disease, but I have a very strong suspicion at this point that that is what she indeed has, and we are going to have to treat it. And we'll talk about how we treat it in a moment. All right. So what is Kawasaki? I think we can jump to that now. So Kawasaki disease is an inflammation of the blood vessels, and we really don't know what causes it or how it happens, but we know it when we see it. And it's usually an autoimmune mechanism, meaning the body is probably attacking the blood vessels in a way, but we just don't know exactly how that happens or why that happens. The way you can think about Kawasaki is by this mnemonic, crash and burn. So how do we diagnose this? What are those clinical criteria we look for? Well, the key is 5. So 5 letters in crash, and it has to be 5 days of these symptoms. So C is conjunctivitis, which is the redness of the eyes. R is rash. A is adenopathy. And so you see this kid has a really big lymph node. Our patient didn't have that, but that would be one of the criteria. S is skin peeling or skin and swelling in the hands and feet. And then H is, oh my gosh, I'm totally blanking out what H is. S is strawberry tongue. Oh my gosh. S is strawberry tongue, and H is hands and feet swelling. I've done this so many times, sometimes I trip myself up. And then burn is fever, so 5 days of fever. And so that's how you can remember Kawasaki. But you really need to be on that 5th day in order to make the diagnosis. Because a lot of these other symptoms, like redness of the eyes, rash, can be commonly caused by a virus, and you don't want to treat prematurely. So how do we treat Kawasaki? We give something called IVIG, which is IV immunoglobulin. And so our thought process behind this is that this probably some sort of autoimmune antibody mediated process that is attacking the blood vessels. And so we give them essentially a neutralizing antibody, which is IVIG or immunoglobulin. And that binds up all of the autoimmune antibodies and really takes down some of that inflammation that we see in the body. We give aspirin for 2 reasons. So aspirin is an anti-inflammatory itself. And so when you give it in a state of high inflammation, it will take down some of that inflammatory response. And also, because of all the inflammation that you're getting, you have a higher risk of clotting sometimes. And so that will help decrease your clotting risk as well. And you'll see here that we have to have cardiology follow-up. And the reason for that is that in Kawasaki disease, because it's a disease that attacks blood vessels, you can actually get a coronary artery aneurysm or dilation of the blood vessel from all of that inflammation. And so these kids have to be followed both in the hospital by the cardiology team. They need to get an echo to look at their blood vessels. And they need to be following up as an outpatient for a pretty significant period of time to help make sure that they don't develop any coronary artery aneurysms. And so that would be this case. Do you guys have any questions on what this case is or what we did, or any thoughts about the condition itself? Have any of you ever heard of this before? Because I definitely hadn't before I started pediatrics, or in medical school, really. Okay, so we have a couple. Okay, cool. So we have a little bit of a mix. Some people yes, some people no. Any questions about Kawasaki? How long after the treatment do symptoms stop? That's a fantastic question. So the criteria for treatment of Kawasaki is actually resolution of the fever within 24 hours. And so if you don't have the fever go away within 24 hours of getting that IVIG, it's considered refractory Kawasaki, and you have to usually give either more IVIG or steroids or more medications to decrease all that inflammation that is happening in the body. So the best part about treating Kawasaki is that when it works, and it's really satisfying. The kid feels so much better. The parents are happy. It's really, really great. It's one of those things you get a pretty immediate response. Someone else asked, is it likely the kids will have a full recovery? Will it impact their lives later? Thankfully, for the most part, these kids recover really, really nicely. There's a chance that they may get it again since they got it once. It's probably a slightly higher likelihood that they will or that they could get it again, but it's very rare. And they do pretty well as long as their heart is not affected by that initial event of inflammation. And so as long as their arteries and the heart look fine, for the most part, they go on to really have completely normal lives and recover fully as if this were just like any other viral illness. Cool. All right. So we can move on to our next case. All right, so we have a 4-week-old boy, previously healthy, who is coming in for 5 days of vomiting and diarrhea. And the vomiting is occurring anywhere from 3 to 5 times a day. And mom describes the diarrhea as occurring as frequently as every 10 minutes. He seems more tired than usual today, which is what prompted mom to bring him into the ED. All right. In the emergency department, the team takes vital signs that are surprisingly normal. And I say surprising because a 4-week-old who's having diarrhea every 10 minutes, I would not expect to have normal vital signs. I would expect their heart rates to be up, or them to have a fever, or their blood pressure to be really low because they're losing a lot of volume. But we're happy to hear for now that his vital signs are normal. He does not have a fever, but when they check his weight, he's 4 weeks old and he actually lost weight since birth. And in pediatrics, you never lose weight as a child. If you lose weight, when a pediatrician hears that, I get really, really nervous. And so I'm very concerned all of a sudden that he's lost weight since birth and he's only 4 weeks old. He should only be gaining weight at this point in his life. And his labs, they get some blood work to check for that dehydration. And his lab work shows that he has what we call a metabolic acidosis, meaning he has an imbalance in the pH in his blood, and he's actually acidotic. And so he has a pH of like 7.15, which is very low. And normally we want a pH of around 7.35. And so that's very concerning. All of a sudden, we're concerned that there's something really wrong with this kid. We need to find out what it is. So the ED starts by just giving him a lot of fluids, and they give him 3 boluses, so 3 rounds of a lot of fluid through the IV. They repeat the labs, but they're still very abnormal. They still show that he has a lot of acid in his blood. So they say, all right, you need to stay. And they call me and they say, hey, I have this kid. He's had a lot of vomiting, a lot of diarrhea, no fevers. He's still drinking formula, but he has really bad acidosis and is not getting better after we gave him 3 boluses. And I say, okay, that's a lot, but let's see what we do with him. So admit him to the floor, give him IV fluids. we continued to give him his home formula. So he's taking Enfamil, which is just like a standard pediatric formula. You can get CVS, Walmart, anywhere. And as he's taking the formula, he's continuing to have diarrhea, and maybe not every 10 minutes, but certainly every half hour, every few hours, he's having some sort of diarrhea. We keep adjusting his fluids. We try to give him some fluids that would maybe buffer some of the acid levels in his blood, but it's really hard to correct, which is pretty unusual. Generally, we are able to correct after a couple rounds of fluids and fine tuning with the maintenance fluids, but we really had trouble getting his acidosis under control. And so we just had this vicious cycle of diarrhea and bad blood work. All right. So in summary for this kid, we have abnormal labs. We have what we call failure to thrive, or this lack of weight gain or weight loss. And there's really no infectious cause for his diarrhea. He doesn't have a fever. No one else at home is sick. We really don't think this is just a stomach bug. So I'm curious, do you guys have any thoughts on what might be causing this baby's diarrhea and acidosis in his blood? And I'll give you a hint. The acidosis probably comes from the fact that stool often has a lot of base in it, like a basic, like base to make things. They have a lot of bicarb, so you often stool out a lot of your base, and then you end up being acidotic because of that. All right, so this one's a tricky one if you have never heard of it before either. So on our differential, one thing that we really wanted to look into was whether or not he has a severe milk protein allergy. And sometimes in kids who have a severe milk protein allergy, they can have a lot of diarrhea because anytime they take milk protein, which is in all normal infant formulas, it causes upset in their stomach, it causes an inflammatory response, and they have really bad diarrhea from that. Some other things that we were thinking of was that this could be a kidney problem because kidneys help regulate the acid-base levels in your body, and he was really acidotic despite everything that we were doing, and so maybe this was his kidneys that was actually the problem, and the diarrhea was just a red herring. And the third thing that we were thinking of that we wanted to make sure we didn't miss was that there wasn't some sort of metabolic inborn error of metabolism, or basically a genetic condition where the body has trouble processing metabolites and just basically doing normal bodily functions. And when you have an inborn error of metabolism, you can also have a persistent acidosis. And something that we were really concerned about with this was that he was only 4 weeks old. And so this is a very common time for something like that to present. So we actually, and this is the benefit of being in a large academic hospital, we talk to our friends, and we have friends in genetics, pediatric genetic doctors, pediatric gastroenterology doctors because of all the diarrhea, pediatric nephrologists or kidney doctors, and we also talk to our allergy friends because of how bad the severe milk protein allergy concern was. All right, and so what we ultimately found with our consults giving us some assistance and lots of labs and also a lot of trial and error was that we made a switch to an elemental formula, or a formula that was really broken down. And all that milk protein was hydrolyzed into a format that was very simple amino acids for the body to digest. And all of a sudden, his diarrhea stopped, his labs got better, and within a few days, he started gaining weight. And so you can actually see here that this was when he was admitted to the hospital, these few points here. I don't know if you can see my cursor, I hope you can. But the second and third points here, he was in the hospital, still practically losing weight. And then right where that star is, we switched his formula to the elemental formula, and his symptoms got better, his labs got better, and he started gaining weight. And so with that, we were able to determine that he had something called FPIES, or food protein induced enterocolitis syndrome. And this is a condition, I just want to see if I have it here, that is an allergy to food, but not an allergy like you would think of to peanuts or something where you have this hives and your airway shuts down and you swell. It's mediated by a different type of allergic process. So we call it a non-IgE mediated food hypersensitivity. And it's very often, as it was in this case, triggered by a food, cow's milk protein in our case. And again, this is different than like a lactose intolerance. This is an allergy to the actual protein in cow's milk itself. And so giving lactose or anything like that won't necessarily help. You really need to stop giving the cow's milk protein. And just like we saw with our patient here, he had vomiting, really bad diarrhea. And because he was constantly getting this food that he's allergic to or has this sensitivity to, he just couldn't gain weight because he was vomiting and having diarrhea for the past 5 days. But chances are it was going on a lot longer. And the scary thing about this is that these kids can come in like this baby, often do fine for the most part for several weeks until at one point their body just can't compensate anymore. And they can come in shock and really have a hard time recovering. As you may have gathered from this baby and this patient, this could be a lot of different things, especially that initial presentation. And so it can take a couple of days in the hospital to rule out everything else before we can make the diagnosis of FPIES. And so that's the challenge here, is that sometimes you have a kid and you're trying everything, and the only way you can make the diagnosis is by doing everything and saying, it's not this, it's not this, it's not this, must be this. All right, and then the nice thing about this is the management or the treatment just means you change formula or you avoid the food. So like I said, most often it's cow's milk protein, but you can also have FPIES to things like oats or certain grains. And so you just have to avoid those triggers, and you'll often outgrow this hypersensitivity by 1 to 4 or 5 years of age. And you basically just follow with an allergist and eventually reintroduce those foods and see if you redevelop symptoms. So kind of an old school medicine compared to that IVIG. For Kawasaki, you really just have to avoid the trigger food, and kids get better really well, really quickly. Any questions about FPIES or food allergies or little babies and things like this? All right. Oh, you have a couple people questions. So how long do the symptoms persist after exposure to the triggering food? So generally only a couple of hours. Once the food is out of the system, it's no longer causing diarrhea or anything. And so in the case with this baby, we started him literally around lunchtime, like after we rounded and made the decision to switch his formula. And by the end of the day, his diarrhea had started to improve. And by the next day, his labs got better. So pretty quickly. And he was on IV fluids, which is why his labs got better so quickly. But his diarrhea improved within essentially hours of removing the food. And then the keys, you just have to be super strict. So you can't even give him a little bit or mix it or anything like that. You have to completely eliminate it and switch over to certain formulas. All right. So just to recap, some reasons why I love pediatric hospital medicine, the rapid turnaround. I like the faster pace of being in a hospital as opposed to ordering blood work or seeing patients, every few months as an outpatient. I like seeing my patients and intervening quickly. I also like the fact that it's not always volume based. Sometimes when you get into an outpatient only specialty, there's a lot of emphasis on seeing a lot of patients because that's how you make money, and you need to make money as a doctor. But in the hospital, you really have a much lower volume of patients just because you can't manage that many sick patients. And so generally I'll see anywhere from 7 to 12 patients a day, where as an outpatient in pediatrics, in general pediatrics, you often see anywhere from 15 or more, sometimes up to 30 patients a day. So I like having a little bit more quality and a little bit more time with my patients. And then in hospital medicine, I also love all of the non-clinical opportunities that come from working in a hospital. So teaching, mentoring, just being involved in inter-hospital committees or intra-hospital committees, learning how the hospital runs. I like having a break from clinical medicine at times, which is really nice for me. Really briefly, for the most part in fellowship. So fellowship happens after pediatric residency, and this is a pediatric hospital specific fellowship. And for the most part, it's 50% clinical and 50% scholarly. So I see kids half the time, and I also work on medical education. I do research the other 50% of the time. And whether or not PHM is right for you, I think is a question you probably all will not have to answer for a while. Once you get through medical school and if you decide to pursue pediatrics, you can decide if you want a career that's a little bit more of a hospital-based program, or if you want to be more in the outpatient setting and a little bit potentially less intense, but also can still be intense as an outpatient in other ways. How many years are residency and fellowship? So for pediatrics, it's 3 years of residency, and for hospitalists, it's 2 years of fellowship after residency. And so it's a total of 5 years. But I did, like I said, a chief residency year as well. So I actually did 4 years in total of residency, and then the 2 years now of fellowship. And my one recommendation that I will tell you now, and you'll probably hear this multiple times, is just that it really doesn't matter. Like, never make a career decision based on what you think the training will be, because like surgery, for example, is usually a 5-year residency and a 1-year fellowship. Like if you want to do pediatric orthopedics, it's 5 years of orthopedic surgery residency and 1 year of fellowship. But if I want to be a pediatric hospitalist, it's 3 years of residency, or 4 for me, and 2 years of fellowship. So I'm still doing like 5 to 6 years of post medical school training. So just keep that in mind. Don't necessarily choose your career based on how long residency or fellowship is. Is it considered extracurricular for your non-clinical time in the hospital? Or is it just part of your job title that you get compensated? That's a fantastic question. And I love that you're asking it, because it's something that is not talked about enough. And the short answer is that as a fellow, it's something I'm compensated for. I have to complete a scholarly project before I graduate in order to be board eligible for hospital medicine boards. And so I basically get paid, and it is an expectation that I do research, that I do some teaching, and that I get involved in the hospital as part of fellowship. When you become an attending, or once you're done with all your training and you're a pediatric hospitalist, that is something that you should be negotiating and asking on your job interview, because it's going to depend on the place that you ultimately go. Some places you have like 50% administrative time, and that becomes a requirement. Other places you're 90% clinical, and anything extra you do is just going to be essentially unpaid work. So you have to ask that question specifically. I said I did a 1-year master program. Was that required? So it was required for my scholarship. And so one reason why I chose NYIT Com or NYCOM was because it was one of the few medical schools that offered like a very clear path for a scholarship program. They have a 2-year tuition reimbursement plus the free master's program if you are accepted. And so this master's program was part of that scholarship, where we taught anatomy class, we taught osteopathic manipulation labs, and we did a research project for the course of the year. And then they covered our tuition for the remainder of the 2 years of medical school. So that's why it was required for that path that I chose. What do you think is the most important part in choosing a residency program? So I think the most important part is that you fit in with the group and that you're honest with yourself about what you want in a residency program. You may benefit in a very small program. You may thrive in a very large program where there's 100 residents. So you take a really internal look at yourself and see what works best for you, because it's not going to be the same for everybody. It's demanding no matter where you go. You're going to work nights, you're going to work weekends. But if you find a community in that residency program that supports you and what you need, that should be how you make that decision. For me, I knew I wanted to be in a teaching position. I knew I wanted to be in medical education eventually. I knew I wanted to be in do some research. And so I was looking for a bigger program, looking for a place that had a lot of subspecialties and a lot of options for me to explore during training. And so that's how I chose my program. How do you deal with burnout in residency and fellowship? It's a great question, and I think there's a lot of answers. But I think for me, the most important thing is knowing what makes you happy and finding a way to keep that at the forefront of your life during training. Knowing that it's not going to happen every day, but that you have to make an effort to do what makes you happy consistently throughout residency. I am actually a huge golfer. I grew up playing golf my whole life. I played in college. I played less and less during medical school. And then the first year of residency, I just never made the effort to play. And then all of a sudden, at the halfway point of second year, so halfway through residency, I realized that I completely gave up this huge part of myself. And I felt that it was really something that was contributing to how burned out, so to say, that I felt during residency. I loved going to work. I loved what I did, but I lost part of myself to my job. And I realized that I couldn't let that happen anymore. And so I actually, in the middle of residency, started volunteering. As if you think you don't have enough time, I started volunteering with the local golf organization, and it brought me back to life. And so you have to stay strong to what makes you during your training. And I promise you'll find time for it. You just have to make that conscious recognition that this is more important than anything else at the moment, and you have to prioritize it. Fellowship, it's a little easier because our schedules are less crazy. And I purposely chose a fellowship where we don't do 24-hour calls and things like that. And so I feel like now that I've kind of put that at the forefront of my goals, to take care of myself, I'm better at incorporating that into my training life. I only have 1 year left. Oh, perfect. We have a little bit of time yet left. Oh, you guys have great questions. How do you deal with difficult and sad situations? How do you not bring that home with you? It's such a timely question because I'm actually on a palliative care week right now. And palliative care is really care that's offered to patients to minimize their suffering. Most people think of palliative care as end of life care, but that's not the case. Especially for kids, when you're diagnosed with a chronic illness that you will have for the rest of your life, you have to find ways to minimize suffering with all the medical things that go on. And so it's been a really tough week for me. We've had a lot of patients pass away, and when I say patients, I mean kids, which can be really hard to deal with. And we've done a lot of debriefing at the hospital whenever kids come in and they pass away, or when kids are really sick and the family's having a hard time about it. We as a department talk about it with each other, and we try to find ways to support each other and make sure that we have either the space or the support that we need during those tough times at work. That being said, there are certainly times that I can't just leave it at work, and it does come home with me. I have a child myself, and my husband is not in medicine, and so he doesn't always understand when I say that it was just a really bad day. And so I have friends who are in medicine and get it, and all I have to do is really just talk to them and say, look, this is what happened at work today, and I just kind of leave it at that, and it helps me get it off my chest when I do have to bring it home with me. And then sometimes it takes a little time, it takes a couple days to really let these tough cases blow over. But the thing I like about peds is that kids are amazing and often resilient. And I think the successes and the happy stories significantly outweigh the bad ones. And then that's what keeps me going every day. And that's why I love what I do. Thank you guys. You had great questions. All right. So I think for the most part, that is all that I have. If you have any questions, I'm going to fast forward to the end of this presentation. We can talk about personal branding if you want, but I think that we have a minute. Let me just say one thing. So one thing I didn't realize when I was doing medical school was this idea of a personal brand. I had no doctors in my family. Everyone was just kind of like, yeah, a doctor's a good career, a solid job, job security. But that was kind of all that I knew about medicine. But I think that it's really important that you start to define who you are within medicine now, because that will help you as you're applying to medical school. It will help you as you go through medical school, as you're looking at residencies. Think about the things that make you you and how you can bring that to medicine, as opposed to changing yourself to fit into whatever mold you think medical school or residency wants to see. And so just real quickly, if you kind of scroll through some big people's names that you might be able to recognize, they all have a personal brand. And when you're creating your medical school personal statement, you should be thinking about your personal brand. And the way I like to kind of briefly help you guys find your personal brand is just look at what you've already done, or think about where you want to be in 5 years. Pick some themes. So for me, for example, I like medical education, I like pediatrics, and I like wellness. And I kind of try to keep those themes in everything that I do. And then everything that I have an opportunity to pursue, I see if it aligns with some of these themes and my true interests. And I really try to limit my next opportunities to something that will only really fit within my personal brand and help me to grow in the things that I love. And so if you want to talk more about that, I'm happy to talk more offline, but I think you should start to cultivate that now and not wait to, fit yourself into a mold for medical school, but build your brand now as you apply to medical school and go through your medical training, because I think that helps with burnout. I really think it helps when you love what you do. And we have one more question. How do you emotionally self-regulate in those situations and not show emotions in front of families? It's really hard. It's really hard. I think you do it with time. When it first happens and you're a new resident or you're in medical school, you often are just watching, and you are often just a bystander in the room, and you're not actually participating in the conversations. And over the course of your training, you become the one having those difficult conversations. And it takes practice. It takes some emotional regulation that you have to be very conscious about. And if you cry with your patient, you cry with your patient. I don't think that's the end of the world. I think the most important thing is that you connect with your patient and that they trust you and respect you. And if that means that you cried when you tell them that their child is dying, then you cry when your child is dying. Thankfully that doesn't happen that often, but you're human and you're allowed to have some emotions if that happens. But you do get a little bit more used to or better at delivering bad news as you go through training, because it is a part of medicine. Sure. All right, well, I can hang out for a few minutes if anyone has other questions. Otherwise, this is my email. I'm on Instagram I think I'm on Instagram for you guys and so that I can interact with and meet new people. But I'm not like a regular poster or anything. I try to every now and then. I sometimes have bursts of more posts, but I think it's a fantastic way to connect with people. And so I stay on as much as I can. And then I have a website that I do a little bit of blogging. Again, I kind of post in spurts, but it's another way to just kind of be in touch with me. And I'm happy to, help you guys if you have any questions. I know it's application season starting up, so I'm happy to offer any advice if you need.
Thank you, Dr. Thea, for an insightful presentation and for taking your time off.
Absolutely. Have a great day, everybody.
Yeah, thank you. And for those of you who are currently attending, we have posted a Google Form link in the chat, so make sure you verify your attendance. We don't have any questions for any quiz for this session. So yeah, make sure you sign up so you can get credit for the session. And please try to use one email throughout so we can track your hours. And we will be handing out the certificates at the end of this semester. So yeah, thank you very much, everyone, for joining us. Thank you, Doctor, again.
You're very welcome. Have a great day, everybody.
Thank you.
Bye.